Thanks everybody for joining today. Given, well, for me at least, it's a beautiful day outside, and I know I'm sure you'd rather be doing much nicer things, but hopefully this is going to be a very interesting presentation. So as Dawn said, it's our first in our mini series for the Year of Data, and that Year of Data is all about us promoting the value, use and understanding of data. So today we're going to look at a piece of work that came out of the big discussion. And for anyone that's not aware, this was focused on really overcoming the winter pressures and started last year. This particular piece of work was specifically around those frailty fractures, and really it's all about making this better for our patients and staff. So Ken Ross is presenting today, and he's currently a senior workflow analyst within Encompass, but he brings a wealth of experience from working in physical rehabilitation, and he is well used to working in a pressurized environment, which this I'm sure has been, and really seeking to get the most out of data. I know Ken will probably mention this, but I think it's important to highlight the team effort in this work. So a couple of names just to mention, and I know there's many more, would be Anne, Chelsea, Landon, and the support of the big discussion workstream for fractured neck of femur. They were critical in really moving this along at pace and delivering. Another, I suppose, key point to call out was that central to this was really sweating the assets that we've heavily invested in. So using Encompass and working with the existing teams to deliver. So I'm going to hand over to Ken, and as Dawn said, please do put your questions into the chat, and then we'll allow some time at the end to pick up on any of those. Okay.
Thank you, Lisa. Thanks, everyone. My name's Ken Ross, a senior workflow analyst working in the outpatient specialties, and I cover orthopedics outpatient workflows. And the aim of today's session was to give a little bit of oversight on a project that's coming to an end. We're almost ready to sign off and hand over a piece of work in relation to neck and femur care in Northern Ireland that Lisa's explained has come about through the big discussion initiative. If you weren't sure what the big discussion was, this is directed down from the Health Minister, brings together service experts to identify the causes of NHS pressures and develop coordinated long-term solutions to improve patient care, one of which is the neck and femur care, particularly in relation to winter pressures, and Encompass our approach to see if we could help with displaying data that might help support this initiative. So it was agreed that we would look to explore the build for a dashboard that could be used as a tool for these discussions. It's also worth noting that 1 out of 5 trusts doesn't currently have an elective trauma and orthopedic service. So as a byproduct of this work, that could help drive the quality of care. So what is a neck of femur? It's the big weight-bearing bone in the middle of your thigh. And basically, as it comes up towards the top, it narrows and takes a bit of a turn before it becomes a ball and sits in the socket of the pelvis. This is particularly vulnerable to anyone who would slip or fall, but more so in those with bone health issues or in the elderly population. And if you're unfortunate enough to break your hip, it's worth noting this is a time-dependent condition. There's a lot of support and evidence and research out there that outcomes are vastly improved if the surgery is completed in less than 48 hours. So this is just a little diagram. Basically,
not even going to put on their uniform, you know, because they don't need it on Monday. And
thank you. So we looked at some of the data entry points that were already being manually inputted by the trauma coordinators and the fracture teams for the National Hip Fracture Database. This is a regulated report that's been collated and submitted through Encompass since Go Live. And that regulated report, captures a number of key data points and KPIs that relate to things like length of stay, time to surgery, and returning to original residence. We supplemented that with some of the events that are already captured within the system as well to improve accuracy, maybe when it needed. And this allowed us to build an end-to-end journey, which you can see here from the first time the telephone call is made right through to when the patient is discharged and then reviewed and followed up 3 months later. We work then with the leads of each phase of care to identify any additional key metrics that could be included. We set out to build 8 KPIs and we end up building 19, but we don't expect all users to be interested in all 19 of the KPIs. We would hope that they would modify a version of the dashboard for themselves that just included the most pertinent information for them, or they can use some of the sort of mini versions that we've created as well. So where are we now? As we'd mentioned, we have a small dedicated working group, myself, Anne McDonald from SPPG, Chelsea Meek, the trauma coordinator at SET, Patrick McCauley and Landon Corson, who are co-keto analysts. And over the last 6 to 8 months, we went through a process and a cycle of building, reviewing and validating. We're now close to sending out the SOP, which will ensure all users are inputting information correctly and in a timely manner. And it'll also be outlining exactly what each KPI is designed to measure. And we then hope that this tool will be handed over to the relevant planners, service leads, and decision makers in this area. And how can this be used? Well, we hope that the stakeholders will be able to have more of a granular overview of their data, and it'll actually be, live data as well. They'll have more insight in the bottlenecks. They'll be able to review edge cases in more detail. There'll be some shared learning there to promote better care and equality of care. And over time, we hope that users will improve their ability to navigate our system to gain insight to what's going on in their areas. And you'll be glad that most of my slides were just pictures. And the next thing I was going to show you was just the dashboard itself. So if you have access to the system, you can go to the analytics catalog and just search for the NOF dashboard, and the regional dashboard will be available to everyone who can find it in there. There's a little bit of an overview about what the dashboard is measuring, and there's some links to other dashboards. Some key things to note. At the very top, you'll see there's where you can go to enter dates where you want to start and finish. And this is like kind of casting the net over the data that you want to capture. So you may want to look at data for the last week, last year, last 2 years, whatever it may be. And you can come in and amend that up in the top corner. You can also create your own version of a dashboard. So you might find that you want to remove a lot of the bits that you already know about and maybe just focus in on 1 and 2 KPIs that you think are most relevant to you. We also have a great piece of work as a reconciliation report. So this can be used, for example, if there was 10 entries inputted through the smart form. If you run that report, the system will essentially check for errors. So we do find that on occasions, data entry can lead to timestamp inaccuracies where maybe people put in the wrong month or the wrong year, and the system will alert by highlighting what patient and what row needs to be reviewed. So we're hoping that will have an impact on data quality. Yeah, and then you'll see the view for some of the stakeholders, like Encompass and SPPG will get a view of all of the trusts, but anyone else will only get to see their trust data. So it's just important to note that as well. I'm going to pause there. There is an ability to go in and review and slice and dice data, but there is a chance that we could be looking at some patient data that maybe isn't appropriate to be disclosed right now, but that would be the majority of my presentation if anyone had any questions.
Thanks, Ken, for that. So yes, I will open up to any questions. I suppose maybe I can start things off, my privilege. Ken, just keen to know like the challenges you faced in trying to set this up so that it would be learning for others and how you overcame those.
Yeah, I mean, it's always difficult to get the right people into the room at the right time. But I think even more so in trauma and orthopedics, I think people are constantly being pulled left and right. So that was one of the challenges. The second one would be mainly that you would assume that everyone does everything the same, and unfortunately, it's not always the case. So some people might use the note to write some bits of information, or some people might sort of discharge and readmit someone rather than transferring them. So yeah, there was a lot of looking at KPIs that we thought would have been pretty easy to implement, but when we looked at the data, we've seen that there wasn't a high enough percentage of users doing the same thing regularly enough, and the data quality wasn't then going to be useful enough to be on the dashboard.
Thank you. I'll go to Linda then.
Always trust me, Lisa, to have a question. This is great for guys working in the team, but I'm a patient. What difference is this going to make to me if I fall and end up in ED? Will I notice any change?
So it's a great question. There are some of the other members of the team on the call at the minute. I don't know if maybe Anne was around, if she felt that would be a question for her. But I think overall the goal would be that while some phases maybe do bits better and others maybe not so well, that over time that shared learning would have a knock-on effect to all patients, because you'd be reviewing the pathway, you'd be looking at improvements, and the patient would have the knock-on effect of hopefully getting through quicker and getting the surgery in a more timely manner.
Can't see, Ken, if Anne is on. I don't know whether any of your colleagues that worked on this from the trust are on, or if you can spot any of them. They're maybe hiding here at this point in time. If they want to come in.
Chelsea might be on the call. I know maybe Chelsea, you have any insight how this might knock on?
Yeah, hello, I am here. Great presentation, Ken. From a patient point of view, this piece of work actually shows that yes, we have found that all trusts do things very slightly differently, which has led then to a lot of shared learning throughout all of the trusts in caring for this patient population. It shows the patient journey right from the first call when they've had their fall to ambulance, right through to their discharge at the very end of their journey, and then allows all stakeholders to see what could be possibly bottlenecks in that patient journey. So from a bit of shared and collaborative working throughout all of the trusts, then they should be able to identify those bottlenecks, put some plans into action to try and improve them, which in turn then will hopefully improve patient care throughout their journey.
Thanks, Chelsea. Peter, do you want to come in?
Get my mic down. Yeah, no, really, thanks for this, Ken. It's one of these things. This is a really good example, I think, of that joint work across the trust and the Compass and SPPG to get a really well-defined piece up. So I was thinking more on the practical elements, because you noted there that iterative cycle that you went through across quite a long period of time. And is there any points that you learned upon as you went through that practical element with the group that would be of benefit for folks looking to do something similar, or any sort of the boons from working in that fashion versus maybe handing work off and letting it work in isolation in a siloed way?
Yeah, I mean, I think the biggest challenge was really getting the right people on the call. I think Chelsea can kind of vouch for that. There was what we really needed was probably like a regular placeholder to check in with the right people on a regular basis, because then we would have, maybe into that sort of sprint cycle of working on something for a period of time and then coming back and reviewing it with everyone that helped sort of kick off the decision. We were limited at times with the ability to do that, but we didn't want to sort of push on and leave any group out. So, we did have to sort of make time and wait just to catch up with the right people at the right time. In terms of the actual build itself, you do need people to feedback on the examples that come from the Cogito team. So they'll maybe pull 10 examples and say, we think we're measuring A to B. Can you have a look in the system for us? And we don't really have the knowledge or the service knowledge to understand if it's being captured accurately. So that was where we were very grateful for, like Chelsea, who was able to, regularly review information for us. But if we were able to have that across all 5 trusts, that would have been even better.
Thanks, Ken. I think there's a wee question in the chat. I don't know whether, Ken, you can scroll down or that potentially goes into some patient data.
No, this is fine. I mean, you've got in each sort of metric, you'll have a title and it should sort of indicate what it is that's being measured. If you want a bit more of technical review, you can click on the information icon and that will tell you where the data source is. So you'll become familiar with it if you're using it regularly, but an SDE would be a smart form entry, and some of the other things like an ADT event would be from our system. So this effectively gives you the two columns that you know the KPI is measuring from and to. And when you go into any of the detailed version of the report, you would just have to look up those two columns. So if you were worried about maybe the average being spiked because there was one or two entries that maybe weren't right, that would give you the ability to understand what it is that you're looking to review.
Heidi, do you have a question?
Yeah, thank you, Ken. That was really interesting. How are you able to identify the cohort of patients in the ED data and NIAS data?
So the way we've worked it, and I don't know if Landon or Patrick is there to support, but essentially everyone that has a neck of femur fracture will have a NHFD form completed. So that's how we were able to identify. We could have used things like diagnosis and stuff like that, but we have used that for other elements. But essentially everyone that has an NHFD form attached to them is one of the patients we're interested in reviewing. So we know that's happening on the ground, that the trauma coordinators are identifying who needs to fill in that form. And sorry, what was the second part of your question?
How you identify them? Do you use NIAS data or is it all Encompass ambulance data on Encompass?
So we don't have any sort of interface with NIAS, but there is a PDF that's uploaded against the ED admission, which includes all the timestamps, such as when the ambulance was called, when they were offloaded, etc. So that's the trauma coordinators were already doing an element of that to complete the smart form. So we did ask them to add an additional 2 parts from that run-up sheet. So rather than just looking at it for 1 entry, they're now looking at it for 3. But that's where it comes from. The source of truth is the PDF that's uploaded.
Thank you. We'll go to Carolyn next.
Hiya. I'm just looking at this now. It looks amazing. There's so much information. My question was really on, was there one part of it, whether it was like one part of the dashboard or one metric that was particularly complex, whether it was complex technically or you needed to get everybody's agreement on it, and how did you resolve that?
Yeah, they all had an element of that. I think that things like transfers were tricky. One of the ones that we thought might have been kind of straightforward was when someone was admitted to like a specialist ward, but it turns out that people aren't always able to be put into a specialist ward directly. Whenever an X-ray was ordered, we assumed that the first X-ray that would be ordered would probably be a pelvic or hip fracture X-ray, but sometimes it wouldn't. They may have had another condition, so it might have been like a chest X-ray that was needed as well. So we did have to continually work with Landon and Patrick to refine the code and narrow things down. But I don't know, Chelsea, if you have any other examples that you can think of.
There were a couple of tricky bits, most of which you have stated already. I think it was just trying to get the right people on the right calls to be able to make sure that we were identifying the correct information moving forward, and then having those little sub meetings and sub calls with all of the stakeholders to ensure that we were gathering the right information that everyone across the board would like and would appreciate in the dashboard. There were a couple of tricky ones that we thought should have been straightforward that maybe weren't, as you said there, the transfers particularly, because the ADT20 code, which is used for transferring patients, can be used then across any transfer. So it was tricky then to try and identify for exactly what the patient was being transferred for. But with a good bit of collaborative teamwork, then we found the workaround solution for that. So I think it was just trying to get everyone together, putting heads together to ensure we're getting the right information for what we were looking at.
Paddy?
Well, I was actually going to ask a very similar question. I think one of the big things so we've done a similar project in palliative care, and we had to really force people to input structured data into flow sheets. And again, if it was just the extraction of complex data, did you have to use any workbench reports to extract some of the more complex if then ands? Because certainly it is tricky to get structured data and SNOMED CT codes out of the Encompass, Ken. So it's probably just more of the same. That's what my question is going to be.
I mean, we were quite fortunate to say that a large proportion of this was being entered manually into a smart form, which gave us a smart data element to work from. Then we had, events. So, for example, we weren't always sure if the time that the surgery was being started was accurate. So we looked within our system to see if there was another way of capturing that. And we ended up looking at anesthesia start time, because that was being 100% of the time logged. And that was what we felt was the most accurate way of capturing the moment just before the patient went under the knife. So yeah, I mean, we were lucky in that we had a lot of good data to begin with, but then when you look at other areas such as like ordering x-rays or what time they were medically fit to be discharged, then we came across things that are a little bit more difficult because those statuses might change, or they might not always order what you expected. So they were the ones that required a little bit more review from our groups.
Hey, Ken, just to speak to that as well. So this whole dashboard is generated off of a SQL script instead of reporting workbench. So we had kind of full ability to customize to really pull any data we needed.
Yeah, that's really helpful, Landon. It looks a bit more sophisticated than that. That's brilliant. Yeah.
Thank you. Tony?
Yeah, I was just wondering what the skewness of the data, or was it sort of quite normally distributed on the timings? Sort of noticed in a few data sets we're looking at now, the median is actually giving you a better picture than the average. I just wondered how that sort of looked in looking at the performance side of things.
Yeah, it's a great question. It might be a little bit outside my scope, if I'm honest, but I mean, Landon, you're able to explain that these are averages of hours, is that right? Is there anything else?
Yeah. So these will be averages in hours. And as Ken mentioned earlier, we have a reconciliation report for the few components that rely on manual entry in case there are any misinputs, just user mistakes. So the idea is if you see an average that looks pretty far off, you can dig into the data, which I don't think we can show here because it'll have patient information, but you'll be able to drill into the data and kind of identify those areas that need to be reviewed, or just may need work and be a bottleneck, like Chelsea mentioned.
Yeah.
Great, thank you. Are there any other questions? I don't think I see any more hands up. I always have one more question. Can I ask one more? So Ken, this was a wee bit different, I think, in that, as we said at the start, it came out of the big discussion. So there was that real drive from a very senior position. And then you had the work stream that was leading on this, obviously with senior SPPG and trust people involved. Do you think that helped to move it at a wee bit more pace to get things done? And obviously with all of the team effort from everybody involved.
No, 100%. I think you really need that directed down approach, I think, to, I guess, maybe highlight the people's inboxes that they need to maybe read this email or get back. So yeah, there's no substitute for that, really.
Great. Okay. I'll do one final check. Ken, I don't know whether you want a final word before we finish.
No, but again, just to underline, like, how much of a collaborative effort this was. I mean, I don't think it could have been achieved without all 4 areas, really. And a special thanks to Chelsea for all the work that she's done on this.
Yeah, agreed. So thanks everybody for taking the time to join us today, and Ken particularly for taking us through that. I found it was really, even though I've seen this sort of in development, it was great to see it in this way. As we said at the start, we have a series of these events throughout the year, so we're really keen that if there are other ideas or suggestions, we're really open to you sharing those with us. So thank you. Hope you all get to enjoy the sun now. Okay, thanks very much, everyone. Bye-bye.
Thank you. Thanks very
Bye.
much. Thank you.
Thank you.